Okay, we're at ACC 2015. Now, back in ESC 2013, routine thrombectomy failed in the TASTE trial. This was followed in 2014 by the results of TATORT and STEMI, published in JACC, showing a failure in, well, and STEMI. And thrombus aspiration has not been able to get a break. So we're back with Dr. Sanjit Jolly, who is McMaster University, Hamilton, Canada, is an associate professor there, and also Hamilton Health Services. And we've had this conversation now, this is the third time, and everybody was waiting for the total trial. So now we have kind of the total results. Give us an idea, first off, of when you started this whole thing, where was thrombectomy?
Yeah, so when we started, the TOPAZ trial had just come out, and this suggested that routine thrombectomy can reduce mortality by 50%. And as a clinician, I felt, wow, this is amazing. This is changing the field of interventional cardiology. But then, a seed of doubt, when you see such a dramatic effect, it's actually bigger than the effect that you see from prime PCI itself. It made me pause and think. And then, during clinical practice, I began to think, maybe we've overestimated this treatment effect. We really need to verify this. And so that was the aha moment in terms of thinking and designing the total trial.
So in terms of the total trial, you started with one population, you actually then made that trial even bigger, if I remember. Tell me about total.
Yes. So we started with a sample size of 4,000 patients. We actually ended with a sample size of almost 11,000 patients. And this was an event-driven trial. So essentially, what dictates the power of a trial is the number of events, not the number of patients. So what the value of this is that we actually know, we're very confident of our results because we had the required number of events, and as a result, we had the planned power that we had started with. And I think that's a challenge in the current era, is that most trials are underpowered, and so you can't be sure if you have a neutral result whether in fact you're missing a benefit.
So what did you find?
So we found no difference for our primary outcome of cardiovascular death, recurrent MI, cardiogenic shock, or class 4 heart failure. And we found no difference in cardiovascular mortality. What we did find was we found an increased rate in the risk of stroke at 30 days in thrombus aspiration compared to PCI alone. And this was an important trial.
So what's the take-home from this, besides being disappointing?
Yes. The take-home is that as a routine strategy, thrombus aspiration doesn't appear to be beneficial and could be associated with some downside risks. So it should be used selectively. The second point is that it's important to note in our PCI alone arm, there was an option for bailout. So in other words, if your PCI alone strategy was failing, so you were trying to open up the vessel with a balloon, and no matter what you did, the vessel remained occluded with thrombus, those patients could bail out thrombectomy, and that happened in 7% of the time. So the message is that thrombectomy should never be used. It should be used in a selective fashion only when you really need it. And that's, clinicians still need to use your judgment, but this trial is helpful for telling us that routine is not the correct approach.
So essentially you're supporting the results originally published from the TASTE trial?
Yes. In fact, this really, both TASTE and TOTAL provide a very similar message in terms of efficacy. Where
is this going from here? Is this like now over-answered and we don't need to worry about this anymore?
I think one of the important unsolved questions, is there any specific subgroup of patients that could benefit from thrombus aspirin? And people have hypothesized that perhaps the patients with the highest thrombus burden, even after you balloon, are those the ones that there could be a benefit? It's a small proportion of the population. We can't answer that at this point, and there may be future studies to address this, but certainly routine thrombus aspiration has been answered.
And very quickly, the last question is, in terms of this makes perfect sense, why didn't it work? Do you have any idea what the mechanism is behind the fact that this just has continued to fail?
Yes. There are several possibilities. One, that we didn't take out enough thrombus with our device. So in fact that some of it still embolized down, and so we didn't get as much of a benefit as we would like. Second, our population is a heterogeneous group. Some had a high thrombus burden, some had less thrombus. That may be a possibility. However, when we actually looked at thrombus burden, 90% of our population had at least moderate thrombus burden. So that perhaps is less likely. I think the final concept is that we believe in this concept, but the heart is a very resilient organ, and so maybe distal embolization is less important. And in the modern era of pharmacotherapy, oftentimes the outcomes of patients are very good. So it may be just very important to get that artery open early, and it doesn't matter how you do it.
Well, this is a conversation we started at ESC some time ago, so thank you, Dr. Jolly, for this. And the paper is in the New England Journal of Medicine, and simultaneous publication with the presentation here at ACC 2015. For all the coverage from this meeting, please see Cardiosource World News, where I'm Executive Editor Rick McGuire.